Yeah, now it is. You can just make it slideshow.
Are the
Yeah.
slides moving?
Yes, yes.
Okay, okay. So the first question is, in MA program, what does MA stand for? And what is the aim of this program? Mother's absolute attachment, mother's affection and attention, mother's absolute affection, mother's affection appreciation. You can type your answers in the chat box, A, B, C, or D. C. So absolutely right. Many of you have written the right answer. The answer is C, mother's absolute affection. So it's a program by National Health Mission, Government of India, which promotes breastfeeding by awareness generation, by providing skill support at delivery points, and by providing counseling supports at community. By various ways, it promotes breastfeeding, right? So it is mother's absolute affection. The ACOG and Society for Maternal Fetal Medicine have replaced the term label with the label term with early term, full term, late term, and post term. We discussed about grading of prematurity in our discussion. So how do you grade full term babies into early term, full term, late term, and post term? So what does full term mean? 38 to 41, 6/7, 39, 6/7 to 41, and so on. So what is the right answer as per you for full term babies? Okay, some of you have written A, some have written B, D, C, A. Okay, so maximum of number have written C. Correct answer is C, 39 to 46/7. So 39 to 41 is full-term baby. So basically the ACOG has divided this the full-term babies into this because we have seen that babies who are born between 37 to 39 weeks are also at risk of higher risk of TTNB and mild RDS as compared to babies who are born after completion of 39 weeks. So they say that all babies, all elective cesarean sections should be done after 39 weeks. So therefore, they call full term only after the completion of 39 weeks. So that it gives a message that all elective cesarean sections should be done after full term, which is 39 weeks plus. So 37 to 39 weeks is early term, 39 to 41 weeks is full terms, and beyond that is post term. So 37 to 38, 6.7 is early term, 39 to 41 is full term, and thereafter it is late term and post term. Okay, so all elective cesarean sections should be done after completion of 39 weeks. That is full term. So as per FBNC operational guidelines for setting up a 4-bedded NICU, how much floor space is required? 100 square feet, 150 square feet, 200 square feet, 250 square feet. For a 4-bedded newborn stabilization unit, mind you, we are not talking about NICU. We are talking about a newborn stabilization unit, which should be there in a level 2 hospital. So when you type your answer, can you write question 3, answer C that way? Because I'm not sure ये C आपने किसके लिए लिखा है? Is it for the previous question or this one? 3C, okay. ठीक है. So answer is C, 200 square feet. So if you look at the facility-based newborn care guidelines, there are three the hierarchies of newborn care. One is newborn care corner, which should be there in all newborn delivery sites, all PHCs, right? And there should be just one bed in the labor room for the newborn care, and around 220 to 30 square feet is enough. Then all CHCs, right, or level 2 hospitals should have a newborn stabilization unit where there should be 4 beds and 200 square feet of area, right? And all SNCUs, all district hospital should have an SNCU where there should be 12 to 20 beds and minimum 100 square feet per bed. So newborn stabilization unit, since the number of equipment required will be lesser, So around 50 square feet per bed, and therefore 200 square feet for 4 beds is enough. For SNCU, the per bed area is around 100 square feet because you will have CPAP, you will have infusion pumps there, and therefore for 12 beds, around 1200 square feet area has been designated. As per NRP 2020, delayed cord clamping has been recommended for all preterm babies for more than 30 seconds if they do not require resuscitation at birth. What is the class of recommendation and level of evidence for this recommendation? Class 2A, level of evidence C, and so on. So you can write 4A, 4B, 4C as your answer. So one person has written D, B, C. Okay. So generally, you need not memorize each and every recommendation as to what is the class, what is the idea of this question was for you to understand that each recommendation in most guidelines have two things. One is class of recommendation or strength of recommendation, and second is quality of evidence. Okay. Level A, level B, level C, level D. So what does quality of evidence mean? That if evidence has good quality of, if a recommendation has good quality of evidence behind it, right? If it is supported by a meta-analysis or a large size RCT, then the level of evidence will be level A or level B, right? But if the level of evidence is quite weak, we don't have an evidence for the question, or then maybe it is from case reports or from expert advice, then the level of evidence will be C, right? So it will be lower down. Okay. So limited that. So A, B, C is the level of evidence. However, what strength of recommendation includes a lot more than level of evidence. So how strongly you recommend a point. It could be class 1 strong, it could be class 2A moderate, it could be class 3, which is no benefit. Okay. So it depends not just on the quality of evidence, it also depends on the cost of that intervention, the feasibility of that intervention, the side effects of those intervention, right? So for example, giving surfactant in early surfactant, right? If you talk about giving early surfactant in level 3 NICU, the quality of evidence is very good. The class of strength of recommendation will be strong. But same surfactant, if the question is, should you give early surfactant in a newborn stabilization corner? The level of evidence is good that the intervention helps, but will you strongly recommend it? No, because it is not feasible. The side effects could be more. Asepsis management will be an issue. Cost will be an issue, right? So the strength of recommendation depends on a lot of things more than evidence. Okay, for this particular thing, the answer is D, class 2A, and B, level of evidence is B. I hope you have understood, right? Next question is, New Ballard scoring is used for gestational age assessment. It uses physical and neuromuscular parameters for assessment. Which two parameters have got a value of 5 in the score? Eye, ear, and popliteal angle, skin maturity and popliteal angle, skin maturity and scarf sign, and lanugo and scarf signs. Okay, so most of you have written B, which is the right answer, skin maturity and popliteal angle. So just two parameters, popliteal angle in neuromuscular and skin maturity in physical maturity, have a score of 5. The Fenton chart for postnatal growth standards for preterm infants includes a period of dash to dash weeks. This is an easy one. Excellent. So all of you have written the correct answer. It is 22 to 50 weeks. So Fenton chart is a commonly used chart in our NICUs. It is a standard chart where the data from normal babies was taken, and they conducted a systematic review and meta-analysis to improvise on data from Babson and Benda. And generally by 4 to 8 weeks post-term, by around 50 weeks, the WHO growth chart is used. By till 50 weeks, we use Fenton chart. However, it does not account for postnatal weight loss. So it is a standard chart, not a reference chart, and it does not account for postnatal weight loss. So many units these days, they have also started using intergrowth 21, which does not have these problems. The uterine artery PO2 of 95 millimeter of mercury. What is the PO2 of umbilical artery? So the PO2 that is supplied to the uterus is 95 generally, 90 to 100. What is the PO2 of umbilical artery? Of the blood that comes from the baby to the placenta. So if you do a blood gas from the umbilical artery, okay, so two of you have written C, 45 millimeter of mercury. That's a wrong answer. It is 15 millimeter of mercury. So baby is supplied a PO2 of around 95 to 100 from the mother. But what comes from the umbilical artery to the placenta is just 15 millimeter of mercury. To remember it easily, you can use a 20, 30, 40, 50 rule. Okay, so umbilical artery PO2 is usually 20. Umbilical vein PO2 is usually 30. Umbilical vein PCO2 is 40. Umbilical artery PCO2 is 50. Okay, so if you do a blood gas from umbilical vein or artery, you can compare the values from these average normal values. Okay. For thermoneutral zone, which chart is used? So if you were to put a baby on in an incubator in air mode, how much temperature will you set? What would be a thermoneutral zone for a baby at various gestation? Zubrov's chart, Monroe's chart, Rolling's chart, or Hayes chart? I think you can answer this by exclusion. So yes, correct answer is D, Hayes chart. Okay, so for babies between, so based on the baby's weight, one can so decide the operative temperature, and the chart is called Hayes chart. Okay, based on this X-ray and heart picture, what is the congenital anomaly? TOF, and which drug intake by the mother can cause this? So TOF, propranolol, PPHN, SSRIs, Epstein, lithium, HOCM, GDM. Okay, so correct answer is Epstein anomaly and lithium intake, right? So, so as you can see in the diagram, the right, there is atrialization of the right ventricle. The tricuspid valve is shifted downwards, and the most of the right ventricle is included in the right atrium. Okay. As per Spagan recommendation, what is the daily vitamin D requirement for a preterm baby? 250 to 400 per day, 400 per kg per day, 400 to 700 per day, 400 to 700 per kg per day. So yeah, so so most of you are confused between C and D. That is the most common confusion. So in the current guidelines, earlier it used to be per day, but the current guidelines recommend 400 to 700 units per kg per day. If you look at the current ESP SPAGN guidelines, it is 400 to 700 units per kg per day. Okay, so let's do 5 more OSCEs. If indicated, varicella immunoglobulin should be administered to a neonate within what time span of birth? 4 hours, 48 hours, 96 hours, or 7 days. So baby is born to a baby mother who has varicella. Within how long should the baby receive? So correct answer is 96 hours. So most guidelines, they say that if the baby is born to a mother and the mother has had varicella within, for 2 days before or 5 days after, then you have to give the varicella immunoglobulin within 96 hours of exposure, right? Caffeine is used for apnea prematurity. Which receptor does it act? GABA, dopamine, adenosine, or aminophylline? Adenosine receptor, that's an easy one. So it antagonizes adenosine receptor. and therefore excites GABAergic interneurons and stimulates breathing. Which drug is given to mother during antenatal period when the fetus is suspected to have CH? So if the mother has a history of CH in the older sibling and you want to prevent CH, the baby or has possibly has CH, so which injection will you give? Dexamethasone. Okay, so dexamethasone is the right answer. C, dexamethasone. So basically, what happens in CAH is most common form 21 hydroxylase deficiency. There is deficiency of cortisol and aldosterone and accumulation of its precursors, right? These precursors are then they form DHA and various androgens, and which causes virilization of a female fetus. So if you have a mother who has a past history of CH in the previous sibling, and the pregnancy has been diagnosed with HCG, you start dexamethasone immediately. Then at 9 to 16, 11 weeks, you do a CVS and DNA analysis. If the baby is male, you stop dexamethasone, right? If the baby is female and the DNA analysis is suggestive of normal baby, then you stop dexamethasone. However, if the baby is female and the DNA analysis of CH is confirmed, then you continue dexamethasone. What dexamethasone will do, it will suppress ACTH, and it was ACTH which was stimulating the adrenal axis in this direction. So it will suppress ACTH and it will reduce the androgens, right? This is the prediction nomogram by Bhutani. What percentile does affected middle line reflect? 40, 50, 40 to 75. What does the middle line reflect? Yes. So middle line reflects the 75th centile. So this nomogram we use for prediction of postnatal jaundice, right? How likely is the baby to have postnatal jaundice? Last question: which candidal species is most commonly associated with colonization of hands of healthcare workers? Candida albicans, para albicans, Paracelolis, and cruzi. Excellent. All of you have written the right answer. It is Candida paracelosis. So I think we can.
Thanks, Dr. Sankar. Thank you very much.
Okay, thank you. Thank
So
you.
very good OSCEs, giving like a wide picture, so now the students know what all they have to learn. Thank you so much for sparing your time.
Thank you, Dr. Kavita. It was nice interacting with the fellows. Thank you.
So thanks to all the fellows. We'll see you next week, Wednesday. Good night. Thank you. Bye, Sarita.